Dear friends, dear colleagues, welcome to another OncoAlert Colloquium focusing on thoracic malignancies. My name is Giannis Mountzios and I'm a medical oncologist from the University of Athens School of Medicine, and it is a great pleasure and honor for me today to present to you the recent therapeutic evolutions within 2025 in the field of small cell lung cancer and also of mesothelioma. So I hope that now you can see my screen and we can start. So 2025 has been a landmark trial for small cell lung cancer and less for mesothelioma, but there have been some significant advances. And I'm starting right away with small cell lung cancer. I'm sure that you are all aware of the natural course of small cell lung cancer, starting with a chemosensitive disease that unfortunately very fast leads to chemo resistance and subsequent clinical progression. And we know that after relapse, the therapeutic options currently are very limited, and usually patients have a very rapid clinical deterioration. So how can we change this natural course? We need to take a step back into the molecular biology of the disease and remember that small cell lung cancer is characterized by two main molecular events. First, the two main cell cycle regulating tumor suppressor genes, mainly TP53 and RB1, are downregulated, knocked out in 95% of cases. And second, we have a deregulation of the Notch1 pathway that combined with upregulation of ASCL1 that mediates epithelial to mesenchymal transition that in turn confers chemo resistance and leads to early relapses. So talking about immune checkpoint inhibitors, we know that in first line we have some positive trials, but the clinical benefit in median overall survival is modest at best and is largely driven by very few cases that derive substantial clinical benefit from immune checkpoint inhibitors. So how can we do better? A first strategy is to intensify during the maintenance setting, and in this sense, in ASCO 2025, we had the announcement of the IM-Forte trial, a trial that combined, as you can see here from the study design, after 4 cycles of platinum-based chemotherapy plus atezolizumab, patients that did not experience tumor progression were randomized to receive either the combination of atezolizumab plus lurbinectedin or atezolizumab alone until progressive disease or unacceptable toxicity, with PFS and OS being the co-primary endpoints. And importantly, this was a significantly positive trial in terms of PFS. The addition of Lurbi to atezolizumab led to a numerical improvement and statistically clinically significant improvement in PFS from 2.1 months to 5.4 months. And more importantly, there was a substantial benefit in median overall survival, which was increased from 10.6 months to 13.2 months. But please keep in mind that those numbers refer to OS assessments that start from randomization into the maintenance phase. So we should also add a median of 3.2 months in each arm from cycle 1, day 1 initiation. So this was a major advancement, but we need to remember that this intensified strategy of combination of atezo plus lurbi is not for every patient. This is the addition of a chemotherapeutic agent, and practically it is something like prolonging, perpetuating chemotherapy or a switch maintenance chemotherapy strategy together with atezolizumab. And as you can see here, there was a numerical increase in all adverse events that are associated with chemotherapy, including myelosuppression, gastrointestinal toxicity, anemia, fatigue, and decreased appetite. So all these things need to be taken into consideration. What about the second line setting? We need to remember that not all small cell lung cancers are created equal, and actually we should see small cell lung cancer like a spectrum of disease, biological spectrum. On the one edge of the spectrum we have the more neuroendocrine phenotypes like ASCL1, like YAP1, like NeuroD1, and on the other side of the spectrum we have the non-neuroendocrine phenotypes, including the immune inflamed phenotype. And actually, this is a complex interplay between molecular denominators that are driving the more neuroendocrine phenotype, like DLL3 and ASCL1, and on the other hand, we have the activation of the Notch1 pathway and the presentation of human leukocyte antigens that is associated with a more inflamed phenotype. So, looking at the biology, we see that DLL3 is a negative regulator of Notch signaling, and high DLL3 synergizes with ASCL1 to mediate neuroendocrine transcription factors that lead to a more neuroendocrine and biologically aggressive phenotype. So DLL3 emerges as an appealing therapeutic target for small cell lung cancer, and we have now a variety of T-cell engagers in our therapeutic armamentarium and also in late clinical development that actually act by binding to the antigenic epitope of DLL3 on the surface of the small cell lung cancer cell, and on the other hand they bind to the anti-CD3, so the TCR receptor of the T lymphocyte, and thereby they engage the tumor cell with the T cell, enabling the antibody-mediated tumor killing of the cancer cell. So we are all aware of the very important trial that was presented this year, 2025, in ASCO with Tarlatamab, which was the first T-cell engager to be approved in this setting versus standard chemotherapy as second-line treatment for small cell lung cancer. This study included patients with relapsed recurrent small cell lung cancer after platinum-based chemotherapy as first-line treatment with or without an immune checkpoint inhibitor, and patients were randomized in a 1-to-1 ratio to receive either Tarlatamab with a step-in phase of 1 milligram followed subsequently by 10 milligram every 2 weeks, or standard standard chemotherapy that comprised either topotecan or lurbinectedin or amrubicin, depending on the area of approval, and of course the primary endpoint here was overall survival. As you can see, the patient characteristics were well balanced between the two arms, and we can speak about the typical second-line small cell population with 2/3 of patients having a PS of 1, 7 out of 10 patients having received prior immune checkpoint inhibitor therapy, and as you can see, almost half of patients having brain metastasis and 1/3 of patients having liver metastasis, while approximately 40% of patients had a chemotherapy-free interval of less than 3 months. This is the primary outcome of the study. Tarlatamab significantly improved overall survival compared to chemotherapy. It decreased the risk of dying from the disease by 40% as compared to chemotherapy, and that was associated with a significant improvement in median overall survival from 8.3 to 13.6 months in the second-line setting. This is unprecedented. It represents a major therapeutic advance in this setting, and as you can see, this benefit was consistent across important subgroups of patients, including patients with chemo-resistant disease, so patients who had experienced disease relapse less than 90 days after end of first-line treatment, and also patients with brain and liver metastasis were benefited from this treatment. And later in 2025, in ESMO 2025, we saw the subgroup analysis depending on chemotherapy-free interval, and as you can see, the hazard ratios were pretty similar independent of whether the tumor had relapsed before or 90 days after the end of platinum-based chemotherapy. This was an important message from this study. And similarly, the benefit was irrespective of whether the patients had received a prior immune checkpoint inhibitor or not. And this is clinically relevant because we know that there was a concern as to whether prior exposure to an immune checkpoint inhibitor could diminish, could reduce Tarlatamab efficacy, but it seems that T-cell engagers and immune checkpoint inhibitors work in a totally different way with a completely distinct mechanism of action. Progression-free survival was also numerically and statistically significantly improved with Tarlatamab versus chemotherapy. But what is also important in my mind is that Tarlatamab produced more objective responses as compared to chemotherapy, 35 as compared to 20%, and patients who were lucky enough to respond, they had a significant increase in the duration of response as compared to chemotherapy. Importantly, quality of life was significantly improved with Tarlatamab as compared to chemotherapy in terms of dyspnea, in terms of cough, and also numerical improvement in chest pain. And we all know that those symptoms can be really bothersome for patients. Other strategies in the second-line setting presented these years include the phase 1b DAREON-9 trial with a combination of obrixtamig plus topotecan in patients treated in the second-line setting and beyond. And you can see unconfirmed objective responses in 70% of cases. This is really impressive, and a disease control rate of 87%, and the DAREON-Lung2 phase 3 trial is currently ongoing. What are the other novel strategies in the relapsed setting? We have combinations of lurbinectedin with pembrolizumab or with durvalumab with immune checkpoint inhibitors, but these strategies are likely to disappear as lurbinectedin moves to the first-line consolidation treatment setting. And also we have this fascinating new drug of agents, the antibody drug conjugates, and there are a number of targets that are clinically relevant for small cell lung cancer: DLL3, TROP2, B7H3, and SCZ6. And we have antibody drug conjugates currently for all these categories that are currently being evaluated in phase 2 and 3 clinical trials in patients with relapsed disease, conferring overall responses in approximately 35 to 40% of patients. And we are really looking forward to the results of these trials in 2026. But apart from that, we also have molecular agents. For example, this bispecific antibody targeting EGFR and HER3 at the same time, IZA-BREN, who has already received breakthrough approval by FDA for pretreated EGFR positive non-small cell lung cancer, seems to be also active in pre-treated and non-pre-treated small cell lung cancer. Especially, we can see here the results of pre-treated small cell lung cancer with objective responses reaching up to 75% of patients and a median duration of response of approximately 6 months in heavily pretreated patients. So this is really a new hope in this setting for our patients. And finally, in the last 3 to 4 minutes, I would like to summarize the important advances in mesothelioma in 2025. So I'm sure that you were all aware of this pivotal trial, the Keynote 483 trial, evaluating the addition of pembrolizumab to chemotherapy in the first-line setting of malignant mesothelioma. And we know for 2 years now from this landmark publication in Lancet that the addition of pembrolizumab to platinum-based chemotherapy plus pemetrexed in the first-line setting was associated with a statistically significant improvement in median overall survival from 16 to a bit more than 17 months. And in the exploratory analysis, this benefit was more prominent in patients with non-epithelioid histology, consistent from what we know from other trials with checkpoint inhibitors in malignant mesothelioma. But this year, here we saw the updated overall survival in WCLC 2025, and we saw that this benefit was consistent, corresponding to a hazard ratio of 0.79, so 20% reduction in the relative risk of death with the addition of Pembrolizumab to chemotherapy, and again the benefit was more prominent in patients with non-epithelioid histology, leading to approval for this subgroup of patients, for this combination by the FDA. Another important trial that merits to be referenced here is the BEAT-MESO trial, a very interesting academic trial by ETOP. The addition of the immune checkpoint inhibitor Atezolizumab to the combination of chemotherapy plus bevacizumab, so a combination of angiogenesis inhibition plus anti-PD-L1, a big randomized phase 3 trial with primary endpoint of overall survival, and we can see here that although there was a numerical improvement in median overall survival, this was not statistically significant and not clinically meaningful, but nevertheless an important trial asking the important question of the combination of immunotherapy with anti-angiogenesis in mesothelioma. And finally, from ESMO 2025, new promising agents in mesothelioma, for example, this YAP inhibitor called VT-3989 in patients with refractory pleural and non-pleural mesothelioma, which was a phase 1-2 study showing promising results, objective responses in a substantial number of patients in clinically optimized dose of 50 or 100 milligrams, and this agent is now moving to further clinical development. So with that, I would like to summarize by saying that we had two breakthrough trials in 2025, Delphi 304 and IM Forte, that have really reshaped our therapeutic approach for small cell lung cancer, leading to corresponding approvals in the second and the first line setting respectively. We have a number of ADCs currently being evaluated in the second line setting and are likely to transform the therapeutic landscape both in the second line setting and are expected to rapidly move in the first line setting together with T-cell engagers. And of course, immune checkpoint inhibitor combinations are refining the first line strategy in malignant mesothelioma, and we have a number of new promising targets that are currently being actively explored in the second line setting in recurrent mesothelioma. And with this, I would like to thank you very much for your attention, and I will be connected to answer any questions that you might have. Thank you very much for your kind attention.